Greetings, everybody. We start in 25 minutes. Okay, we start in 20 minutes. Welcome, everybody. Yes. Yes. Greetings, everybody. I come into a resounding round of applause. Testing 1, 2, test. Can you guys hear me okay? Hello, Juha, you in there yet? Welcome, Juha.
Can you hear me, John?
Hey, how you doing? Hello, who's this?
I don't that there is no camera connection now here. I don't know why, but you can hear me?
Yes, we can hear you.
Okay, so how many minutes? I will give a short introduction. There is
Okay.
no camera connection now. I cannot get camera connection. I'm sorry.
Oh,
I'm in
really?
Shanghai, so
Well,
yeah.
just so
I'm in Shanghai. I try my best, but
okay, that's
I will
okay.
go to my room. So I
That's
will give
okay.
a short introduction.
Okay,
Yeah.
but Juha can do audio. He can do audio, right?
Hmm?
Juha will be able to do audio. He can commentate, right?
I can, yeah, but I don't have any picture here.
I know,
try
but
to
that's
start the
but
video,
that's
but
okay.
they say that there is no. Okay,
Okay.
I will.
Well, listen, that
Monen
doesn't matter.
huoneeseen pitämään lyhyen.
We do not need your picture. We do not. Can you hear me?
10 minuutissa on.
Can you hear me? We do not need your picture. We just need your
I will see in
comment.
10 minutes back. I will.
Okay, can you hear me? You can do the sound, right?
Okay.
You can do the sound. You can do the sound.
Get the picture.
You can do the sound, right?
Okay. There's no
You know, just the sound.
See now.
Hello,
Start video.
Z. Hello,
Unable to
Z.
access camera.
Hello, hello, Z.
Okay.
Hello,
So I can.
hello, Z. Hello, Z.
But I can speak. Hello. Yeah. So 7 minutes. So I will give a short introduction. Yeah.
Okay, so you can talk, right?
I can talk, but I don't get any access to camera. I
Okay,
don't
that's
know what is
okay.
going on, but there are.
Listen, we do not need camera. We do not need camera. We do not need camera.
No, I just wanted to show myself in. I just wanted to show myself that I'm there, but I can talk. Just tell me when to begin. So I give a short introduction.
Okay, that's good. That's all we need.
Yeah.
Audio.
And Subin has some emergency. He will be a little bit late. So
okay. Okay.
Many things happening now.
I know. We'll do okay.
I cannot translate in Chinese, you know.
That's okay. That's okay. We'll do it. We'll do it the best we can.
I think Liao is Louis Borba, excellent lecturer. So we are like how to go side persons. But of course, Subin Takashi is there to translate in Japanese.
Okay. Okay, a tool goes here. That's good. Juha, a tool's here.
Five minutes.
Okay.
Yes, my dear John.
Hey, Tool, how you doing?
King is there. Hello.
King is here.
Hello,
The king is, we're ready to start. The king has arrived.
Yes. Juha, how are you?
Okay, very good. We start in 5 minutes. Juha is in Shanghai. We're kind of putting the internet connection together over there. We have his audio, right, Juha? We have your audio. So Juha will be able to give the introduction.
Yeah, I can discuss, but I cannot get any picture here. So I see that there is an excellent discussion, will be excellent discussion with Atul is there involved, and so there will be heavy discussion on the skull-base surgery.
Yeah, we're covered. Atul is here.
Is Louis Borba there? Is Louis there?
Dr. Leo is not here yet. but a lot of
Good
people
evening.
like to
He
ride
sent me
a
a
lot.
message.
Hello,
that he's
Takashi, welcome.
waiting
Good evening.
So, Takashi.
Dr. Goer. So
Hi, Dr. Takashi, how are you?
I am very fine. So I really enjoyed your lecture about brain tumor, glioma.
Oh,
Very
yeah.
impressed. Yes, you first. Yeah, also very informative.
Yeah, we broadcast that a tool. Did you get
Yeah,
good numbers? Did you
yes,
get good
yes.
numbers?
Yeah,
More than 1,000 people
Great.
were there,
Yeah.
quite a big, huge.
Yeah, we
Yeah.
helped you. We helped you there.
Of course, you are there. Your smile is there with me, John.
Yeah, that's it. Yeah, but that was a good one yesterday. That was a good one.
Yes, that was very successful one.
Yeah,
Victor
this
is
week
here.
very interesting lectures and Dr. Kobayashi's and Dr. Fukushima, Dr. Kawase is also, Dr. Ohata also. Many Japanese tycoons are very informative lectures. So really enjoyable website.
Hello, how are you?
Victor, how are you, my friend?
Hey.
Fine.
Hello, Victor.
Very nice to see you, Dr. Takashi, Dr.
Good evening.
Hello.
Welcome, Victor.
Welcome.
Okay, a couple minutes.
Borba is there or no?
Lewis is coming in now, I think.
Atul Goal.
Victor, my friend.
I am doing this kind of models. These are made in scale 1:1.
Okay. Very good. This is on the patient or you are...
No, this is plastic made, plastic, resin.
Yeah. Yes.
And
this is
this is very useful to training, to
That's
put
right.
to put screws.
Oh,
You can make, Victor, for each patient specific.
Oh yeah, with
Okay,
3D
Lewis is here.
print.
Lewis is here. I'm sorry to interrupt you there, Victor. Hello,
Hey.
Lewis. Good morning.
Morning,
Welcome.
Morning.
Professor Goyle,
Tony.
Yeah, Luis.
the
How are
king
you,
of
my-
Zoom. No,
Yeah.
if you
Yeah.
watch your presentation, you don't need to do residency. See, just watch your lecture every day will be wonderful.
Yeah, he's a producer. He's the king of Zoom.
Yeah, I know.
Lewis, he's the
Exactly.
king of Zoom.
Exactly. King of Zoom.
King of Zoom.
Lewis, we're kind of hindered by Juha's audio is not working too good. You're there, right, Juha? He's in Shanghai, and he's in
I'm
Shanghai.
here, but
Yeah.
I cannot send a picture from here. So it is
Okay.
no
but you-
connection with people. I will give a short introduction to begin.
Okay, we'll do that.
Can
do
you
the
hear me?
introduction. Yes. No, loud and clear. Okay, you ready?
Louis
Juha?
is there?
Yeah, Louis
Yes,
is
I'm here.
Okay, Juha, we're starting. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett with Juha's China Neurosurgery Grand Rounds. We have the pleasure of hosting Louis Borba, MD. He's a famous skull surgeon and a great guy and a great educator. And he'll tell you about what he's going to do with his organization, Flank. And let me turn it over to Juha to give a proper neurosurgical introduction to Louis. Good morning, Juha. Are you there, Juha?
Hello, everybody, dear colleagues. I speak from Shanghai without picture. We have the great pleasure to have Professor Louis Borba here presenting on skull-based surgery in the times of radiosurgery. So it is difficult to find a person who has a better training than Professor Luis Borba. He happened to go to fellowship to Little Rock, to Professor Al-Mefti, and then Professor Yasaki arrived there, and also nowadays Professor Ugur Ture and Professor Ali Christ were there. So famous company together. So, and then Professor Luis Borba was having a 3 years fellowship in Little Rock and certainly did a lot. He studied skull base, and Ugur Ture was doing the fiber dissection. So extremely good company and changing the knowledge and research, and great heroes to support them. So after that time, we went back to Brazil and made excellent school of skull-based surgery, and has been giving extremely good lectures all around the world, and now during the COVID time, excellent webinars. So we are extremely pleased to have you, Luis, here. And
thank you, sir.
please go ahead. You have times as much as you wish, and just continue, tell your experience. So we are waiting for you. Please go ahead, Professor Luis Borba.
Okay, thank you, Professor Juha. Professor Juha, one of the giants of neurosurgery. Professor Juha, a great educator. Professor Juha, a great man. Professor Juha, a man that you still follow. When he left Finland, went to Nepal to help the people. Now he's in China. And now with this greenhouse, he's teaching the world how to be a neurosurgeon, how to keep the real neurosurgery alive. The neurosurgery that you learn, we love, our dedication, in our passion. Thank you, Professor, to be as you are. Thank you to keep the real neurosurgery real on track. And pleasure to see here also Professor Atul Goyal. He's a great man, great surgeon, also the same, eager, try to follow his steps. He's much older than me, but I try to follow him. Professor Takashi, Professor Vitor Hugo, and one of the greatest neurosurgeons in the world, Professor Bing Shu. Thank you, all the participants. I will start to share my presentation. Can you see my slides? Can you see my?
Yes.
Yeah, good. Okay.
Perfect.
Today, I remember when I was in the residency, before the residency, I was in the medical school, and I started to love neurosurgery. Is the time that the skull base was coming. Very large approach. Arrived the tumor. They say total removal. The MRI was just coming. Sometimes the MRI showed that it was not total removal. The patient's deficit, oculomotor deficit. Cavernosinus was the area that everybody wanna learn, everybody try, and after some time, the cavernosinus becomes a prohibited area. If you talk about cavernosinus surgery, some years ago, maybe nowadays, some people will say, oh, this man is crazy. You cannot touch the cavernosinus. You cannot, the carotid artery, the nerves, you cannot touch. But in everything that happens in life, we go to extreme to one side and extreme to the other side and try to follow the balance. And the balance is everything that you do in life. And neurosurgery is the same. Today we are in the area of endovascular for aneurysm, but we know that unruptured aneurysm will be treated better with microsurgery. But in some countries, in some places, you say, oh, you open the head. The cavernous sinus look like to be the same devil. First, around my disclosure, everything that I learn is skull-based. I try to follow my mentor, Professor Lomefti, with a little bit changes if I learn with my time and learn with my own mistakes, learn with the mistake of my friends, my teachers, and learning every day. Is the way that Dr. Lomefti also give me the way to do it. I coming from a city in south of Brazil, we call Curitiba. It's like a small town, like a village in China. We have 3 million inhabitants. It's in the south of Brazil. In the corner here, we have the Iguaçu Falls, the famous Iguaçu Falls. And Curitiba is the city in the world to have more green per person. See, it's 51 meters green per habitant. It's a nice and very conservative and very nice city. You see, you enjoy to come here. But let's talk about the cavernous sinus by itself. And I concentrate just in meningioma, maybe some words about pituitary in there. When you see the lateral wall of the middle fossa, the floor of the middle fossa, you see the lateral wall of the cavernous sinus. What you see? Nothing. Maybe vein and dura. And here are some of the pathology of the cavernous sinus. You may have an intracavernous aneurysm that today the treatment is totally dedicated to endovascular or nothing to do it. You know, Professor Juha, I'm seeing here, and Professor Goya, I'm seeing here more and more in Brazil, patient has a headache, does a MRI or angio MRI and show a very small intracavernous aneurysm, 3 millimeters, 4 millimeters, and flow diverter. It's crazy, it's crazy. We also can have tumor that's coming from the nerves. The trigeminal schwannoma is not in the cavernous sinus, but can push to the lateral wall. The chordoma can come from the bone and can displace the cavernous sinus, simulate like an invasion, but majority of the time not a real invasion. And you can have the cavernous sinus meningioma that can be inside the cavernous sinus or coming from outside to inside. The most important to understand this anatomy that you see some tumor from the clinoid area, some tumor from the pectoris apex, some tumor from the tentorium can be around the cavernous sinus and invade the cavernous sinus from outside to inside. But there are tumors also that is coming in the origin, they are rising inside the cavernous sinus. Our dream in cavernous sinus surgery do like this. You have the anatomy, optic nerve, carotid artery, V3, third nerve, fourth nerve, V1, V2, sixth nerve, third nerve, carotid artery, V1, V2, V3, and clean. But there is one area here, see? Look this. All the nerves come together. And here, all the nerves are separate. This is cavernous sinus. This is the end of the cavernous sinus, the superior orbital fissure. The behavior in the possibility to remove and to treat this tumor is completely different, and the approach will be completely different. Does not mean approach open the head. The approach talk about decision. Now we are in the era of the radiation therapy. This paper, 1987, from San Francisco by Professor Charles Wilson, shows that radiation therapy helps some meningioma. You gain time. See, the time of recurrence double when you do radiation treatment. But does not mean that the patient totally cured, does not mean that the disease is totally controlled. It means that you gain time. See? There is a dance in Brazil that is, you go and the ladies start to dance by speed 1, 2, 3, 4, 5. And she start to move her body, see, related to the speed 1, 2, 3, 4, 5. And I will say here, see, meningioma is like this. You change from step 1 to step 2 to step 3 with radiation therapy. See, it's like moving the body in the dancing, in the Brazilian dancing, in the samba. But what makes more worry for the young generation and for us that love neurosurgery and live neurosurgery is this. Look, Professor Juha and Professor Goyle and Professor Binshu and all the participants. This is the WNS, American Association of Neurological Surgeon meeting. I think the largest meeting in the world. I know in China you have more people, but this influenced the whole world, this meeting. When you go to the exposition desk, you see this. Lexel gamma knife for this. Man, look at this tumor. Look at the attachment here. See? Very small. You can go there, do a very simple retrosigmoid approach, go to the tentorium, cut the attachment, and remove the tumor. And cure the patient. Don't need radiation. And this is the advertisement from the company. Please, let's tell the truth to the neurosurgeon. Let's tell the truth for the patient. This beautiful lady asked to her father, to get an iPad. And she got it, iPad. Look at that. Here, the patient is searching for cure, and they offer this. Maybe we have to change our behavior. We know that radiation therapy works for cavernosinus lesions. I'm not saying that is the best option. I said it works. It's example here, cavernous hemangioma. Today you know that radiation works. The effect of radiation, the long-term result of radiation, the complication, the long-term is different. Talk about image. The image here, see? Cavernous hemangioma. Pre, post. Very good. Trigeminal schwannoma. Pre, post. It's okay. Complication, trigeminal neuralgia, and other kind of complication, new tumors, transformation. It's happening. But talk about image. Okay? It works. But the literature, you get this. Meningioma treated gamma knife. Oh, tumor here. Posterior part of the cavernous sinus. That part that I showed that the nerves are separate. Good. Pre, Where is my mouse? My mouse was here. I lost my, okay, my mouse here. See, tumor here. See, oh, looks good. No biopsy. But the great majority of the time that we see in the patient with cavernous sinus meningioma is this. Treatment, tumor, was partially removed, they leave this part, give radiation therapy. Okay. Okay, now it's work. After some years, the tumor come back crazy like this. And I have tumor here, have tumor here, have tumor here, a tumor in everywhere. This is the natural history of cavernous sinus meningioma treated with radiation therapy. At least the patient that I see. I know that the people that does radiation say, oh, have thousands of cases that nothing's happened, the patient's happy. I did radiation therapy and nothing's happened. Another advertisement about radiation for meningioma. This is radiation-induced meningiomas, okay? Induced by radiation meningioma. We know that you need to remove. We know that you need, in the post-op, if you cannot remove, give radiation, of course. The behavior of this tumor is different. But look the example in the literature. Look the size of the meningioma. Professor Go, this tumor we can remove. Our first year resident can remove and give a 10 centimeters margin for this tumor. And this is the example in the paper for radiation stereotactic radiosurgery. If you want to show something, show the real good example. What makes me more surprised and maybe sad, it's famous skull-based surgeons are co-author of this paper. The people that's talking about radical removal through the nose, they go through the nose to everywhere. Look at this. Give fuel for the fire, gasoline for the fire. And now came a group, our nice French group. They decide to study the natural history of cavernous sinus meningioma. Look what they found. 78% of the patient, the symptoms regress with corticosteroids. 90% of the patient, the tumor, the symptoms didn't come back. I talk about meningioma in the cavernous sinus. The small one that we see in the lateral wall of the cavernous sinus, that sometimes the patient has some diplopia, temporary diplopia. Look at this. 90% increase. 71% stable. 9.4% decrease. Look at this number and compare this number with radiosurgery. Would be very similar. Very, very similar. When you go to the paper and see what the complication that they have, and the 5 cases that they say that they couldn't control the tumor growth, they treated with radiation therapy or radiosurgery. See what's happened? Unchanged, 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 unchanged. Decrease 30%. One decrease. But see what's happened? Secondary complication. Radiation-induced meningioma. transform a benign meningioma in a more aggressive meningioma. For the residents, for the young people that is listen and will watching during the next days, does not mean if you have a tumor in the head, benign tumor, that you need treatment. Sometimes watch and see can be the best treatment. 66 years old, female, just headache, no vision loss, no deficit. See, hypertension, morbidity, lesion, oh, surgery. Man, this lady has no symptoms. This patient is living her life very quietly and okay. Some headache that you need some aspirin. Maybe this patient should run away from the neurosurgeon, from the radiosurgeon, and see the ophthalmologist. If the patient starts to lose the vision, you can do a conservative, how you say conservative? Surgery that is remove the enteroclinoid, decompress the optic nerve, maybe do the peeling of the middle fossa, and wait. Don't need to go there inside there and remove. It's possible to remove cavernocyte meningioma? Of course. This inside cavernocyte meningioma, not the coming from outside. Of course it's possible. You can, it's a video, see, you can see the carotid artery here, you can see the V3, the 4, and the 3, the third nerve, the fourth nerve, the pre-op and the post-op, and the third nerve recovered, but not totally. See? We'll come back. It was 3 months after, 6 months after surgery. It will be better, but always there is some price. Maybe you don't need to do this. If you have a case like this of ophthalmoplegia, incomplete invade the cavernous sinus, and see, you can do an oncological removal and take the tumor out. If you want to do skull-based surgery, you need exposure. What the size of the craniotomy? The size that you need. Of the size of the approach? The size that you need. Sometimes you need large, sometimes you don't need large. We know today that 90% of the skull-based tumors or skull-based lesions, you can remove by a classical paternal approach and the classical retrosigmoid approach. Skull-based surgery does not mean skull-based approach. Skull-based approach, I talk zygomatic, petrosal, transcondylar, something. Skull-based lesion need to be removed or wait, or radiation. You need to treat sometimes, or sometimes do it. The approach, you decide to each case. Yesterday, my fellow that's coming from northern Brazil, he said, Dr. Borba, which approach you do to next case? Will be different than the other one. I do the anterior petrosal approach in this case. Okay, but every time you change a little bit, of course, I change a little bit to adapt the situation. To have this perception, we need to go to the lab to understand the anatomy and to understand the behavior of the tumor. If you go to the lab and go to dissecting, you learn how to do the unlock the cavernous sinus. You go there, extradural. I do extradural removal for tumor and intradural removal of the clinoids for aneurysm, because sometimes you don't need to remove too much clinoids to clip aneurysm. You see, do the peeling of the middle fossa. Peeling is peeling. Peeling is not cutting. You see the lateral of the cavernous sinus, the optic nerve. Now we are going to the posterior part. You cut the middle meningeal artery. See, peeling is peeling. Here is V2, and go dissecting. These veins, if you have tumor, not bleed too much. If start to bleed, you use fibrin glue, but not too much fibrin glue. Not too much. I know this technique was created by Professor Juha, and after some people copy and popularized, but Professor Juha was the man that had this idea. You put the glue in the small bleedings, but not too much, not too much. Now we're coming extra, intra, the superior wall of the cavernous sinus. You see the carotid artery, you see the third nerve, you see the fourth nerve, see? And you go liberating the structure. See, here look like tumor that invading the canal. See, you open the optic nerve sheath, you clean this direction, and follow. Just follow where the tumor take you there. For meningioma, you need to remove much more dura than you do in the other kind of tumors. This is the anterior part, and the posterior part is for the tumor that's coming in this direction here. If there is extension posteriorly, you can go posterior and remove the petrous apex. See, the trick, dissect from anterior to posterior, not posterior to anterior, and parallel to the skull base. Try to identify the great superficial petrosal nerve. I have to tell you here, this month I have my first case of facial palsy, the peeling of the middle fossa. I wanna cry for this situation. I did the peeling, I dissect the great superficial petrosal nerve, but the Gacerium ganglion was exposed, and was terrible complication, terrible. You have to be careful with this. See the great superficial, now take the dura back. We'll drill the petrous apex. Watch the trick, go inside. See, this is something, here's the superior petrosal sinus. Go inside the bone, the petrous apex, drill the bone from inside to outside until you find the dura in the posterior fossa. Okay, when I open the dura posterior fossa, I like to open a little bit to take more CSF. I always take CSF intradural first to relax the brain, and after come to the petrous apex. Now it's coming here. During the posterior fossa, during the middle fossa, what's happening in the middle? What you have in the middle? The superior petrosal sinus. The idea is to cut, coagulate. You can put glue to the anterior part, but never use fibrin glue to the back. To the anterior part is, I think, safe. For the posterior part, is not safe. Now you identify the tentorium. You go trying to search for the fourth nerve, but you cannot see. Ours is underneath. You cut the tentorium, you communicate the supratemporal with the infratemporal compartment. Follow it back, and the fifth nerve will be here, the posterior fossa. What's the trick of the anterior petrosal approach? What is the trick to unlock the posterior part of the cavernous sinus? Is totally liberate the five. See, they were stitching the posterior part of the tentorium to displace back. When you find the fifth nerve, you totally liberate the fifth nerve. You see the root, dissect in this lateral wall, lateral part of the Gacerium ganglion and the trigeminal nerve, not in this anterior here. The anterior will be the six down here. See the five? You can mobilize the five medially, laterally. You see, you follow this part here. Now you can see where is the fourth? Fourth is here. Fourth is very small, you see. You take this dura here. This tumor will be like tumor of the tentorium that is invading the area. And this is the posterior part of the cavernous sinus. It is the Bernasconi-Cassinari artery that's coming from the meningohypophyseal trunk to the tentorium. What's the trick to find the 6? How to find the 6? I'll just separate the 4, okay? How find the 6? Where is the 6th nerve? 6th nerve will be just here. You see V1, you open a little bit more the Parkinson triangle. This is work like tumor. If you don't have tumor here, you don't need to do that. If you do that, you need a lot of glue. You open this posterior part, not this anterior part. This anterior part, the superior orbital fissure. This is the limitation to remove the cavernous sinus tumors. See the superior orbital fissure, the cavernous sinus meningioma. See the 6, the artery. See the trick: elevate the 5, elevate, put lateral. You can find the 6th nerve. That shows some case. The people say that it's cavernous sinus tumor. It's not cavernous sinus meningioma. It's anteroclinoidal meningioma. You can do the peeling of the middle fossa. You can dissect this part. This way you can see and cut the vascularization. The tumor is outside of the cavernous sinus. This is the best to do this. In some situations, you can use the same approach to just decompress the optic nerve. You see? Let's say you have a tumor here. You remove this small tumor. You open the canal, homolateral, contralateral, and decompress. You don't need to remove this part. Is there? There is another situation that's like this. The tentorial meningioma that is going to the Meckel's cave and going just displacing the cavernous sinus or just invading the Meckel's cave. It's not a real cavernous sinus meningioma. The people say, oh, it's cavernous sinus meningioma. No, it's just follow the trick. What's the trick here? Follow the 5th nerve. If you follow the 5th nerve, you find the tumor in the part. Another situation, this case is very interesting. The patient came to me to do surgery. The first approach for the people say, they say, oh, go to the posterior fossa, remove this part, and leave this part into the cavernous sinus. If you look at the image here, see, there is something here. What's it? The 5th nerve. It means that the tumor is not in the cavernous sinus. It's in the Meckel's cave. In the tumor, the main supply is from the tentorium. You just follow the tumor from the posterior fossa to the middle fossa. This way you follow the 5th nerve in the part that was supposed to be in the cavernous sinus, and not in the cavernous sinus. You do the surgery. In this case, I did the Petroso approach, and I follow the nerves. You see the 5th nerve here in this place. Here's the Meckel's cave, middle fossa, left side. Okay? See the 5 here? And the tumor that was in the tentorium, in the Meckel's cave, and I follow the 5th nerve from the middle fossa to the posterior fossa. And you have all the tumor here. The 4th nerve is there. The angle given by the Petroso approach in the middle fossa, in the posterior fossa, you follow it. Just follow the route that the tumor gave to you. I did anterior presigmoid and retrosigmoid because this tumor had a small extension under the jugular foramen. You see the 5? Just follow it. See, and the 4th, and the vessels, and the brainstem, and just following the anatomy like this. In the tumor that was impossible to remove, just following the tumor and follow the anatomy. This is the basilar artery here. You can do safely the surgery. And the post-op, pre-op is, press-op is, pre-op, post-op, pre-op, post-op. Look at this. And look at the lady, the Brazilian Japanese lady. See? Look one side, another side, you preserve. See? Just follow the tumor, understanding how behavior of the tumor. You have situation like this. This was my first case. Now I have 5 cases like this. I collect the 5 cases I show. Try to publish together. Tumor in the posterior part of the cavernous sinus. My first case, the patient had no pain. I was thinking maybe inflammatory, maybe cancer. I thought meningioma, diplopia, too small tumor. I'm not sure. I gave high doses of steroids, and I decided to do a biopsy. I see, some years ago, I do a biopsy. This, I see what's this. Maybe meningioma, maybe cancer, maybe inflammatory disease. I see. And I did the surgery, totally extradural. When I arrived here in the Parkinson triangle, what I found a very small meningioma located in the Parkinson triangle. And I could come here, did the peeling of the middle fossa, find V1, displace V1 inferior, the fourth nerve superior, and find the tumor here. Was the beginning of the meningioma. After that, I did more cases, and I'm more aggressive, not more in these cases now than I was before. I was just watching. But if in this case, the patient has tumor very small, localized, like round, you see, like a ball, it's completely different if the tumor comes, like attachment, the dural attachment, take the whole superior orbital fissure. The tumor is located in this posterior part here. The tumor is here, okay? The tumor is not in the superior orbital fissure. The tumor is just here, see, this part here. If the tumor comes here to the superior orbital fissure, in my hand, I cannot remove without that. For me, superior orbital fissure invasion by meningioma inside the between the nerves, in my hands, I cannot remove without destiny. But if the tumor is here in this part, it's completely different. In the post-op, which side was the surgery? See here, see the head? In the post-op, in the lady, see? And pre and post the cavity, and pre and post the cavity. What I do more for tumor that invade the superior orbital fissure? What was proposed by Professor Caldwell, and now is Professor Dolenk agree totally with this idea that we can do the decompression of the cavernous sinus and just leave, see, the nerves can breathe. You give some life to the nerves, just removing the anterior clinoid, removing open and dissecting, decompress the optic nerve, do the peeling of the middle fossa. You can do this in anatomy. You can do this in surgery. Superior orbital fissure for me is the great limitation of the surgery of the cavernous sinus. Look at case, large tumor here. I left a small piece here. It just follow the lady. See, preservation of oculomotor function. Follow the tumor. If the tumor starts to grow, maybe you give radiation, maybe you can give radial surgery to the limited area. But sometimes the tumor remain quiet, doing many times. Another situation like this, large tumor here, some part in the cavernous sinus, patient sixth nerve, you did the surgery. You did the surgery, V2, V3, sphenoid sinus, optic nerve, carotid artery, and leave the part that in the superior orbital fissure. You can liberate totally the nerves, see? And there is tumor under here. Of course, there is tumor here, see? You follow this part to the posterior fossa, you follow the fourth nerve, follow the third nerve, you open the superior wall of the cavernous sinus, but this area here, in the superior orbital fissure, I prefer to leave this. Because in my hand, it does not work well. And I believe that you should tell the truth for the patient, should tell truth. See, you feel how the space of fat, see, to give some space. See, the sphenoid sinus here, let's open the sphenoid sinus. Oh, here, let's follow here. Fat here in the sphenoid sinus, fat here in the sphenoid sinus. See, you follow it in, see. Okay, in the post-op, you have this pre-op and post-op, if preservation of the function. To end, I want to say that about cavernous sinus meningioma, radical removal is possible. The superior orbital fissure is the main limitation. Secondary invasion of the cavernous sinus by meningioma make the removal much more feasible. Asymptomatic cavernous sinus meningioma should be observed and followed with ophthalmology exam. We do not advocate radiosurgery for improved tumor. Just wait and see what's happening. Just one word about this. The people who ask about pituitary adenoma, I'm sure that people will ask about it. This is completely different. Everything that I said to meningioma, you cannot apply to pituitary. It's completely different. The indication to treat cavernous sinus invasion by pituitary is this. The patient has normal function, patient has uncontrollable GH and prolactin tumor, Cushing disease, non-function tumor when it's growing. In the pituitary, you can go, you can see the tumor, you can do the surgery. The patient in the post-op will wake up with deficit, but you can dissect totally the cavernous sinus here. See, you can remove the tumor, and in the post-op will be like this. Sorry. This is pituitary. You have deficit and recovery totally. It's completely different when you have a meningioma. Just a final word about this pituitary surgery. Thank you, Professor Juha. Thank you, all the audience. I think I spoke too much here. It's a great pleasure to me. I'll be open to discussion with all the panelists. Thank you.
Okay, Louis, thanks. Great. Thank you very much. I'm going to ask Atul to lead the discussion because Juha's having problems with his audio. Atul, are you there? Perhaps he stepped away.
No.
Oh, is that?
Oh,
Yeah.
okay, Atul, go ahead.
Just
all
a
yours.
minute. So, my dear Borba, what a
Yes, sir.
fantastic presentation and beautiful pictures that you showed. You know, the issue is, the problem is, there are two problems. Problem number one is that not many people have that kind of experience. Not many people have that kind of anatomical understanding. Not many people can do these things safely. Not many people want to struggle and do dissection. People want to find the easier way. That is one issue. You know, we are neurosurgeons, we have to do technical work, we have to do anatomical work, we have to do philosophical work, and also, even if you are experienced and if you are very experienced, the chances of injury always remains. So issue number one is that we have to be terribly experienced to do a good cavernous sinus surgery, because cavernous sinus surgery is like any other neurosurgery. You have to remove the tumor and you have to be safe. You cannot say I remove a temporal tumor and I take away the optic tract. You cannot say I remove the brainstem tumor and make hemiplegia. You cannot say I remove eloquent brain tumor and I create damage. So for every neurosurgery, our aim is to remove it nicely, to remove it beautifully, and to remove it safely. So the same principles hold for cavernous sinus. The question is, You know, radicality of resection is one thing that we have to be radical. Second is safety of resection is another thing, and it is very important that we remain safe. The issue is that if you do not want to take up these kind of, heavy neurosurgery, then you are not real into neurosurgery. So one lesson that Dr. Borba has given us is that we should all train ourselves in anatomical work, and then train ourselves in basal surgical work, and then do a beautiful resection. And it is possible to remove these tumors safely and radically. As far as the effect of radiation is concerned, you see, radiation, no matter what is said, radiation has its own effects and counter effects and bad effects. So radiation and chemotherapy should come only and only when our knife is not able to reach that destination. If our knife can remove, there is nothing like that. But if the knife is not possible and knife is risky, then the issues of radiation and other things can come in. These are, radiation you give, whether it will affect or whether it will not affect, nobody knows. But when you use the knife and remove it, you can see what you have removed. So if you have to do real treatment, if you have to do actual treatment, you have to use your knife and your skills, and you have to remove the tumor. Hypothetical, you give some drugs here and say it will take effect after 2 years or 3 years. You give radiation, it will say, it will take effect in 2 years. So those are hypothetical treatments. What do you say, Luis, about this? Unmute. Luis, unmute.
Yeah, okay. No, Professor. With the time, we are learning our own limitations. And we have to be true with yourself. See? Sometimes I say, oh, I try to do radical removal, but it's not bad for the patient. And sometimes the problem, sometimes the people don't understand that you need to see case by case. In some case, you can. Sometimes you cannot. When you learn this, more you do, more you have the anatomical background to understand the tumor, to understand the disease, and make difference. This is make the real difference. The radiation therapy, the radiosurgery, is a wonderful tool. Wonderful tool. The endovascular is wonderful too. The chemotherapy, that some people talk about that, is a wonderful tool. But we need to know the right way. And one thing that's very important, a tool that you always say, money never can be an issue. I know that around the world today, money is an issue. Not money to the doctor, money to the hospital, to the public, to the healthcare system. Oh, don't need the surgery, don't need to spend too much. Bite a little bit, go home the other day and burn. Do not treat the patient. We're not doctor to do this. We're doctor to treat patients, not to make business.
What Professor Borba is saying is that we have taken up neurosurgery, and we have taken up this branch of neurosurgery to accept challenges and defeat the enemy in the best possible fashion. We have to train our young people in anatomy. Young people, they have to know how to remove the tumor and grow into tumor removal. And as you do more and more, you become safe and safe. So that is the thing. The best treatment for the patient is do good surgery. The question is whether you can do it, whether you are capable of doing it, whether you are able to accept that challenge that, yes, I will do it, or whether you are not ready to accept the challenge and say, okay, radiation is good and all those things. Radiation will come only when you are defeated by the tumor, when you have lost the battle, when the surgeon says, I cannot do it. So we should train people who say, yes, I can do it. Yes, it is possible for me to do it. And also for the patient, it is not just pseudo yes. We have to say, yes, I can do it. And yes, I can do it anatomically, and I can do it safely for the patient, because these are benign tumors. Most of them are benign. And one sentence, Louis, I had made earlier in my several presentations I had made, and I know you will not agree with that. And even Bin Zhu is sitting, he will say he will not agree with it. So one sentence I am making, and you say whether you agree or you don't agree. My sentence is, you see, you have to remove the tumor radically, okay? But you can never remove the tumor completely to the extent you can say that I have cured him. You can never cure a person.
No.
The tumor will recur, and recurrence will depend on the tumor biology, on the tumor DNA, the tumor growth pattern. Once a tumor, always a tumor. Once a meningioma, always a meningioma. Once an acoustic, always an acoustic. So the surgeon should not say, okay, I have removed the tumor completely. I have taken the third nerve, I have taken the fifth nerve because I wanted to cure the person. So that attitude in a surgeon should never be there. My statement is, the extent of tumor resection does not indicate the recurrence rate. So this is against the theory of Simpson and against the concept of Al-Mafti, who says you do zero resection and you can cure the person and all. Means, of course, Al-Mafti is our teacher, and he says that you should do it radically, and more radically you do, recurrences are less. But I'm saying radical, leave some tumor on the facial nerve in acoustic tumor, leave some tumor on the third if you cannot peel it. Because you are not there to cure the person, the recurrence will depend on the tumor pattern, growth pattern. What do you have to say, Louis?
Yeah. First, I say that I agree totally with you. I agree totally. There is no cure. You may be cured. Depends of the behavior of the tumor. Of course, the biology is the most important thing. The other thing, there is no total. Because what's happening, we're not doing an oncological remove. Oncological remove, you take the mass and margin. The margin in the skull base, you need to take the carotid artery, all the nerves and everything out. You have margin, see? Margin to the tumor. There is no oncological remove, see? We know that more you remove, if this tumor is benign biologically, better it will be. Does not mean that you cure the patient. But the word cure has been used not only by surgeons. I don't use the word cure. I use more radical removal or control, never total. See? They're using by another kind of treatment. See? And one thing that is very important, Professor Goy and all the participants, I was talking with Linda B. Linda B, she is a neurosurgeon from Brigham, from Harvard. She's a great researcher in meningioma. I asked her, why, when you do radiosurgery for acoustic, I do surgery for acoustic, but the people do radiosurgery, it's okay. When you do radiosurgery for acoustic, it's very rare, very, very rare. You see some malignant transformation, very rare. But when you do radiation for meningioma, it's not rare. It's not common, but it's not uncommon. You see, it's very rare. Do you know why? The cell, the behavior in the response to the radiation is different in the cell for meningioma and for acoustic. See, But what you drive the whole evolution is the biological of the tumor. You see, a lady, you do 45 years old, you do a radical removal, progesterone positive, estrogen negative, to a lady 45 years old, you do not so radical, there is remain a small tumor, progesterone positive, estrogen negative, Ki-67 low. The possibility this tumor grow again is very low. Same situation, radical removal, progesterone low, estrogen high, Ki-67 high. This tumor will come back because this tumor is different. And this tumor is still grade 1. They're not grade 2, they're not grade 3, they are grade 1. We have grade 1, and grade 1. See, the trick that today the research didn't answer to us, which one grade 1 will have a bad behavior, which one you have a good behavior. We have some topics like Ki-67, chromosome alteration, genetic, and progesterone and estrogen. You can do this. More you see this, more you understand the biology, better will be the treatment. But you need to be prepared to do surgery.
Another thing, Luis, I want to know from your experience. You see, there is a tumor which arises from the lateral wall of cavernous sinus and remains in the lateral wall of cavernous sinus. One tumor which arises from the roof of cavernous sinus remains in the roof of cavernous sinus. And the tumor which goes inside the cavernous sinus, like goes inside. So my experience with the tumors which are just attached lateral wall of cavernous sinus, they are histologically, not all histologically, they are more benign. If the tumor goes inside the cavernous sinus, involves the fifth nerve, you see, if it is in the Meckel's cave, it is more benign. But if it goes and involves the Gaussian ganglion and the V1 and V2, it is inherently, when it goes inside the confines of the dura, it is more aggressive and the recurrence rates are inherently high. What is your opinion?
I don't have the same opinion. What I'm seeing that when the tumor invade bone, when the tumor invade the superior orbital fissure, when they grow like go to the muscle, invade the muscle, they are more aggressive. The tumor that totally inside the cavernous sinus, like a dural attachment, you see? Very common, you see a meningioma, that the cavernous sinus is the same size. It's not growing like this. The cavernous sinus is the same size, okay? And you have enhancement, you have some meningioma. These are more benign than the tumor that is invading to the infratemporal fossa, that invading the bone and invading the area. This I see here. The other thing that is very important for the resident you see here, the relation between meningioma and breast cancer and some disease that's estrogen and progesterone related is very common, very common. I always ask to the patient about the family. Very common you see some patient and has meningioma and some relatives had breast cancer, or the mother or the sister or some nephews, some relation. These relations, I would say that meningioma is a benign version of breast cancer. See, It is very, very important to understand this. But this meningioma is unpredictable. No, you never know which one will be good. No. Professor Toll, I'm sure that you have case, large tumor, and the patient is asymptomatic, and the patient go to the waiting list, and the patient, like in Brazil, disappear. It come back 5 years later, and the tumor is the same size. And the other tumor, it's very similar. 6 months, he come with edema, you see, and histologically, grade 1 meningioma. It's confused. It's confused.
Yes. Bin, Dr. Bin, you're there?
Yeah. Hi, Go. And hi, Borba. Congratulations.
Hello,
very nice presentation. So
thank you.
You mentioned the level of estrogen may be related with meningiomas. So how about the age? So you still consider the age for your treatment, because when estrogen become the level decreased after it's maybe 70 years old, this a female
and the
patient,
tumors not grow more.
Yeah. So you will leave it, just observe, or you still to do the surgery?
It's case by case.
Mm-hmm.
Case by case. If the patient has a large tumor with edema, that not only the tumor, but edemas make that a mass effect. Maybe you need to, very common you see old patients with 70 something with olfactory groove meningioma. Big ones here. I have to take it. It's a big mass effect. But if the patient is older than 65, okay, and the tumor is quiet, small tumor, no edema, calcify, wait and see. Sometimes nothing's happened. All the thing that the people always asking is about the use of anticonceptives. I don't know if you the word anticonceptives for avoid pregnancy. I don't know if the word is this. See, if hormonal replacement. The people ask about this. I have a patient with meningioma. If you can take hormonal replacement or use anticonceptives. Two things. Is not proof that hormonal replacement makes meningioma. It's not proof. But is proof that if you have a meningioma and you do hormonal replacement, the tumor can grow. See? Because in this situation, I tell the patient, don't make hormonal replacement. See, the ladies want to kill me, you see, but is the tumor can get a different behavior. The anticonceptives, see, if it is related more progesterone, maybe you can take it. Try to avoid estrogen. But the number of people that use anticonceptive is so high, it's so large, the numbers. When you compare with meningioma, if you talk with gynecologists that work with this area, they say, no, there is no relation. I have thousands of patients, there is no relation. But we see the other side. See, always there is some history or hormonal. I had a very nice case. A lady had a very small meningioma in the petrous apex, very small. See, and she start to go to the gym, okay, to be strong like this. It's time to make this crazy thing that they do it. You see, everything that can get, they inject here, they take here to be like this. The tumor was small, become like this. Had relation? I don't know. She took hormones, testosterone, GH, see, and everything that you can imagine. The tumor grow. Is a just a case report? I don't know.
So, Ben, you have any other question, Ben?
No. So how about the texture of the tumor? Because, you know, sometimes it's soft and moisture, so this kind of maybe grow faster. Some is very hard and it's grow very slow. So what's your opinion?
I think the soft tumor is different. It's a different meningioma. But sometimes if you remove the tumor and remove the dura around, in skull base, always is hard. in the area here of in the petroclavus, sometimes it's soft. Petroclavus sometimes soft. Craniocervical junction is a hard. 90% is very hard. In petroclavus, it's more soft. See, there is some relation. I'm not sure that there is a strict relation. When you have calcification, it means that grows slowly. I don't know, Dr. Gold can say something about that, but this relation is, in my mind, is not so clear. And neurofibromatosis, meningioma and neurofibromatosis has a different behavior. They go faster, see, and they get more. But it's the genetic disease. It's not the meningioma by itself.
I will summarize this for you. You see, Ben, all meningiomas are different. Like your fingerprints. Every fingerprint is different. So all meningiomas, you cannot have two meningiomas same. Even radiologically, you know, some meningiomas are going in the sinus, some have wide attachment, some are more vascular, some are soft, some are edema, some are more edema, some are having. So all meningiomas, like fingerprints, are different radiologically. That is one. All meningiomas are different during surgery. No two meningiomas are absolutely similar. So that is number two. And more important is, all meningiomas are different behaviorally, means they behave differently. So there are no two meningiomas which are having the same kind of characters. So the best thing is, you know, we have to have our mind open and wide and our understanding big and philosophical. Some are soft. Soft are, you know, soft does not mean they are more aggressive all the time, like you are saying. Calcified does not mean all the time they are less aggressive. Although when there is calcification, they are more defined and they are less aggressive. Calcified means long-standing tumors. Soft means they will be encasing blood vessels. They are soft and they are more aggressive. But the behavior of every meningioma is different. So that is the bottom line. The histological parameters, you see histology of any meningioma, no two meningiomas are similar. Every tumor, every meningioma has different kind of cell pattern. Suppose every meningioma was same, our neurosurgery would have become a very boring subject. Suppose every meningioma was in convexity here or here, and we do a craniotomy and remove it. So our subject would have become very boring. So that is the reason that it should not become boring for the surgeon. God has made every meningioma different. And that is what we have to learn and understand. Ben, that is what I have to say. The other thing about surgery is, surgery can create, and like in cavernous sinus you are doing, you can create an immediate third nerve palsy. But radiosurgery you can give and it will, you after 6 months, it can create third nerve palsy. It can create temporal damage. You can create epilepsy. You can create mutism. You can create an means difficult deficit. You will realize after 5 years of radiation, you will get a deficit. So the difference of deficits is in surgery is that you get a third nerve palsy immediate after operation. You will say that if I had given radiation, there would have been no deficit, but radiation deficit may come after 5 years in the form of convulsion, in the form of temporal lobe deficit, in the form of visual deficit, in the form of third nerve deficit, in form of aggressive changes in the tumor. So there are complications everywhere. No treatment is, these are all strong treatment. Radiation is a very strong mode of treatment, and you can have strong complications. So we have to be, surgery is the best if it is done properly, learned properly, performed properly, philosophically. I think we have to become good neurosurgeons. We have to become very fantastic neurosurgeons. Technically, that is one, and philosophically, that is more than number one. Louis, for your final comments, and then we will have to close it.
I think Juha, are you there? Do you have something to say, Juha? Can you hear us okay?
I thank you.
Oh,
Hello. I thank you for a wonderful lecture, great discussion. I'm sorry I lost some parts because of the bad connection, but it was excellent. It was an excellent lecture, and we certainly those who had good connection enjoyed it very much. So we are very happy and proud to have you here, Louis.
Thank you.
And we hope in future we can meet again here in our webinar.
Thank you.
Thank you very much. Thank you, Subin. Thank you, Takashi, for translating. Of course, our great Atul. Big thank you for great discussion, and John for great work. Thank you very much.
Ben, you have to make a comment.
Oh, thank you, Luis Borba. Thank you.
Thank you.
Excellent. Yeah, actually, I also learned a lot because mostly I only do the vascular disease. So today I come home a little bit late. So sorry for that. And we have the annual Congress of the Chinese Neurosurgical Society. So today is the first day. So we are very happy to have you here, and I think a lot of Chinese neurosurgeons watched this webinar.
Thank you.
Congratulations.
You could. Gracias, Victor.
Dear Professor. Congrats.
We could.
Victor,
we could stay the whole day here.
Victor, please go ahead. Victor.
No, congrats, dear Professor Borba. Very good discussion. Radiosurgery is a magnificent technology, but it's not for every country around the world. So that's the reason we should work very hard with neurosurgical anatomy and also in surgical techniques. Could be very good, but it's not the same for all the countries. There are many countries do not have radiosurgery. So that's the reason that we as educators, we have to work very hard with neurosurgical anatomy. Thanks a lot for your excellent lecture, Dr. Borba, and thanks everybody.
No, Victor, you could stay the whole day here. It's a pleasure and honor in the very nice talk with Professor Goel, Professor Schultz, Professor Juha, you, and all the participants. If you bring a glass of wine, or maybe a whole bottle, you stay 2 days here talk about this. It will be wonderful. Thank you very much.
Today we totally have 1,100 audience. Yeah.
Okay, good. Thank you. Thank you.
Great job, Louis. Great job. Thank you.
Great job.
Thank you. Thank you.
Professor Goel.
Hey. Good evening. Hi. Thank you for a great talk, and Dr. Borba. So